Hello friends, welcome back to Tiwari Cancer Trust. Today we'll be starting series on gastrointestinal cancers. So before we begin, let's have a look at this pictorial representation. As you can see, it highlights the gastrointestinal tract. What exactly it means is, when we swallow food in our mouth, it goes into a tubular structure which is called the food pipe, or in medical terms an esophagus. This esophagus connects mouth to stomach. Now what stomach is nothing but a bag-like structure just underneath the diaphragm. Whatever we eat is actually stored in the stomach for a while, where there is lots of acid and other gut hormones which eventually break food particles into finer pieces, destroys the germs and bacteria that we swallow, and makes it into a pulp which is pushed further into the small intestine. The small intestine you see here in the diagram in light pink color is the main part of the body where food is digested and the nutrients are absorbed. The residue left over is then pushed further into the large intestine, shown here as a brown colored tubular structure, which is much wider than the small intestine. Now this large intestine, also called the colon, the main function is to absorb water and increase the volume of the residue. Finally, it forms stool within this large intestine, which is expelled out through the anus. So let's start with the first topic, esophagus or food pipe. There are different conditions that affect this food pipe or esophagus. The most common one are the ones which we will be discussing here. The most common benign condition, which is a non-malignant condition, is called a Gastro-Esophageal Reflux Disease, or GERD. It is also commonly known as acid reflux disease. Now why this happens? The place where the esophagus joins the stomach, there is a sphincteric mechanism which prevents retrograde reflux from the stomach into the esophagus. Now, as you might know, that the stomach contains a highly acidic environment due to various kinds of acids, especially hydrochloric acid, and the pH can be as low as 2. So what happens if this sphincter is lax due to a variety of reasons? This acidic content refluxes retrograde into the esophagus. Esophagus is not trained to handle so much of acid, as a result of which there are changes in the structure of the area, and this eventually might lead to various kinds of complications. So how do patients present when they are having GERD? Most of them have a burning sensation in the chest, which is commonly referred to as heartburn, usually after eating food, which might be worse at night on lying down. They may have some chest pain, difficulty in swallowing, actual regurgitation of food or having a sour taste in the mouth, and sometimes feeling of a lump in the throat. So why GERD occurs? The most common factor contributing is the obesity. Again, the other one is hiatal hernia, which is a type of hernia that occurs in the area, reducing the strength of the lower esophageal sphincter. Pregnancy, because of the rise in the intra-abdominal pressure. Smoking, eating large meals or eating late at night and then immediately going off to sleep. Eating certain kinds of food may act as trigger, such as fatty or fried foods, drinking large amounts of beverages like alcohol or coffee, and certain medications such as aspirin. So what happens over a long period of time when this reflux keeps happening are that area gets scarred, and this scarring is what is referred to as esophageal stricture. The other may be that there may be ulceration in the area, but the most difficult one is the change which becomes pre-malignant, and that change in the mucosa is called a Barrett's esophagus, which has a very high chances of turning into malignancy. Now these lesions can all be picked up by an endoscopy, which I would be telling you what exactly it means. And the most dreaded complication is in esophageal cancer developing over a Barrett's mucosa. GERD is most commonly treated using various kinds of antacids and tablets, which such as H2 receptor blockers and proton pump inhibitors. Their main function is the antacids, they coat the area so that the healing occurs, and these tablets, they help to reduce the acid secretion in the stomach by various mechanisms. However, although I have written it below these medications, the most important things are to control your lifestyle with active physical exercise and good dietary habits. Certain resistant cases may require surgery. In a very simple way, I might tell you that in surgery what is done is the upper part of the stomach is actually wrapped around the esophagus, so that the sphincter, the lower esophageal sphincter, is reinforced, and this procedure is called fundoplication and is nowadays done easily with the help of laparoscopic surgery. Now I'll tell you something about cancer affecting the esophagus. The risk factors of the same include the Gastro-Esophageal Reflux Disease, as we just discussed, obesity. It's more common in the Western countries in the male population, where the dietary composition is more of fat and red meat but less of fruits and vegetables, which are known to have lots of antioxidants. Then compounded are use of smoking and alcohol in large quantities, and Barrett's esophagus. There is a particular length which is considered quite ominous, and it affects more than 3 centimeters of the lower esophagus. So how do patients present? Most of them are asymptomatic, but they only have symptoms as the disease advances. Why is it so? Because an esophagus is a hollow tubular organ. The tumor grows mostly inside the lumen at first. So by the time patients presents with symptom, more than 50 to 75% of the lumen has been compromised. The other important feature to understand is that this esophagus or the food pipe is in intimate relation with a large number of vessels and other adjoining structures such as the windpipe or the trachea. And an advanced cancer actually goes and infiltrates or involves all these organs, making resection or removal of the cancer extremely difficult and sometimes out of question. The other features that patients may have are significant weight loss because of continuous depletion in the oral intake and also the effect of tumor per se. There might be a few cases presenting with vomiting of blood, which is called hematemesis, or passage of dark tarry stool, which is called melena in medical terms. Few patients also have odynophagia, which is pain during deglutation, and there may be signs and symptoms of cancer spreading widely, such as incessant pain, or there might be a fistula between the windpipe and the esophagus when the tumor is far advanced into it, and patients may have continuous coughing. There might be small glands appearing everywhere in the neck, or pain in the right upper abdomen where the liver is, and it's because the disease has spread right there. The diagnosis of any cancer involves a thorough clinical examination and physical examination as well as history, detailed history, but every cancer has its own specific investigations. The specific investigations we do for these luminal cancers, the first one would include an endoscopy. So what is an upper GI endoscopy? As you see in the top upper photograph or a diagrammatic representation, endoscope is nothing but a long tube which is flexible, carrying a light source at the tip and also a camera with various kinds of channels which help us to inflate or push air into the system or also to take biopsies. Now this procedure is usually carried out after due counseling of the patient without any general anesthesia, and although it does cause a little bit of discomfort, is manageable. So what, as you can see, is done in this procedure is we introduce this endoscope through the mouth down into the food pipe, visualizing the entire extent of the GI tract right up to the duodenum. Any lesion which is picked up by this examination and appears suspicious, a small bit of it is taken out as a biopsy. Now in the lower two photographs, you see on the left hand side is a normal food pipe. You can imagine the mucosa is nice and red with no other abnormalities, and there is a small hole in the center. So esophagus is basically a muscular tube with a small lumen. However, if you see on the picture onto the right, there is some kind of a unhealthy mucosa and a growth which appears to be malignant growing into the esophagus. Now once we pass this endoscope, these are endoscopic pictures, you can see how well it comes. A sample of it is always taken as a biopsy. Now we come to the treatment of this esophageal cancer. For any cancer nowadays, surgery is not the only treatment. It's actually in intimate relation with other important branches, which includes medical oncology, that is a science which deals with chemotherapy. Then there is radiation oncology, which is concerned with the radiation aspect, and finally the surgical oncology, which includes the surgeons. So most of these cancers of the esophagus will receive some kind of treatment before surgery in the form of either chemotherapy or chemotherapy along with radiation. There are various studies to show that patients then subjected first to these protocols, which is called a neoadjuvant treatment before surgery, have a better chance of surviving as compared to those who undergo upfront surgery. So what we do in surgery basically is that the entire esophagus with cancer is removed en bloc, that means in toto and together, not in piecemeal, and the diseased esophagus after being removed is replaced by forming a tube through the stomach. Now this surgical procedure is known as an esophagectomy and can be done either through an open traditional approach, where we use long incisions in the thorax or the chest as well as in the abdomen and sometimes even in the neck, or through keyhole surgeries, which is called minimally invasive esophagectomy, and nowadays we have robotic techniques also to help in the procedure. As you can see in the photograph down and to the left, there is a tumor affecting the esophagus which has been removed. On to the right and the top you see the incisions that are traditional in an open esophagectomy, and then the second photograph, which is an operative photograph on to the right, shows a stomach tube which has been fashioned out of the stomach. So this stomach tube will now act as a new esophagus. It is fashioned with the help of medical staplers, and it can be done even without staplers as well. Now this stomach tube is now stitched to the part of the esophagus where it was transected or cut and then joined together. The joining of two ends is called anastomosis. This is a major surgery in oncology, and patients need to be admitted for at least a week or 10 days at times, and there might be various kinds of complications of the procedures, in which some of them would be a leak, where what we mean by leak is that the two ends that we join together do not heal properly, and then there is a leakage of the contents of the stomach or the saliva. The other major problems may include the pulmonary complications, that is lung infection and collapse of the lung, etc. So it's quite a major procedure. So with this we conclude today's series on esophagus. Please do join me for the second series on stomach and various kinds of problems that patients have in stomach. See you again. Thank you.